Beautiful. Okay. All right, guys, I'm going to go ahead and start then. Okay. Thank you all for being here. I really appreciate it. So I talked to David about this, and, I feel like everyone's, talking differently about where the value is, the value capture is in the Alio patch. I think it's just best to go over the current business model of dialysis. I'm going to, just so you know, initially treat you all like you're stupid and don't know anything, and then kind of go into the patient experience, and then go into the reimbursements, how nephrologists make money, how dialysis providers make money, and where the Alio patch kind of fits in. Okay, so let's just go ahead and start. So the current healthcare system is a fee-for-service system, right? Fee-for-service. When you bill something, you get paid. You see a patient in clinic, you get paid. When you see the patient in the hospital, you get paid. You do a surgery in a patient, you get paid. You see a patient, you admit a patient in the hospital, you get paid, right? So it incentivizes you to do more for a patient, but not necessarily do better for a patient, right? So you see them more, you do more procedures, you get paid. What this incentivizes you to do is, again, do more, not necessarily better, okay? Now this is the dominant system we have in this country, a fee-for-service system, and Medicare, traditional Medicare, is a fee-for-service system. It's paid off in three different ways: A, B, and D. Part A covers hospital costs. Covers hospital costs. Part B covers outpatient procedures like doctor's appointments and outpatient procedures. Part B covers dialysis. Okay. And then you have Part D, which covers home medication. Again, all these things are paid in a fee-for-service way. As you go along and do them, you get reimbursed for them. Okay. Now, the thing you need to know about kidney disease and Medicare is Medicare has a very special relationship with kidney disease, right? As we know it, Medicare in the United States is a age qualifying insurance. You turn 65 and you qualify for Medicare. Right? That's how we typically do it. Now, there is an exception to that rule, the diagnosis of end-stage kidney disease. And that happened in 1972. In 1972, President Richard Nixon extended Medicare benefits to people who need dialysis services. So people can be 30 years old, 40 years old, and they have Medicare, okay? Now, the thing is, in 1972, we only had about 10,000 people on dialysis in this country. And in 2016, we had 500,000, okay? In 2016, Medicare fee-for-service paid over $114 billion to cover people with kidney disease. That's $1 in every $5 spent on traditional Medicare. Now, that's total for kidney disease, not just dialysis patients. Dialysis patients cost about $30 to $40 billion. But if you're covering all of kidney disease, it's about $114 billion, or patients with kidney disease.
Hey, Qasim, quick question for you.
Yeah.
The rise in numbers of dialysis patients, is that proportional to the rise in population? Or is there a higher preponderance of it today, or do you know?
I think it's actually going up faster than the population, and I think it's generally because of the prevalence of diabetes and high blood pressure and obesity that leads to it. You got to remember, I didn't put it in my slide, but 65 to 70% of people on dialysis are there because of diabetes and high blood pressure. Right? That's what they're there for. They're not there for the autoimmune diseases or like polycystic kidney disease or all these other weird diseases. They're there because of diabetes and high blood pressure. So the prevalence is going up, and it's because of, I generally believe it's because of diabetes and high blood pressure. Now, can I tell you the exact proportion it's going up versus the prevalence of diabetes? Not necessarily, but I wonder that. And, is that's, well, I wonder, like, when in 1972, when we had 10,000 patients, how much of the population of America did we have? Right. So I can't really tell you, but I would say the prevalence of diabetes and high blood pressure is really, and drawing that up. Whereas the result of the current fee-for-service model, 90% of the dialysis patients are on in-center hemodialysis, meaning they do go to a center outside of the house to go to do dialysis. They're not at home in the comfort of their home doing dialysis. They're going to a center. You have more hospitalizations. You have worse outcomes. You actually have late referral to nephrologists, and that means they're close to end stage. What that means is that the typical time when a patient gets referred to a nephrologist is when their kidney function is less than 30%, when they're stage 4 or stage 5. And what that means is, like, at that stage, there's not much I can do for them, right? I'm only kind of trying to maintain them as much as I can, and eventually have a talk about dialysis. Then you have the phenomenon of patients crashing into dialysis. And what this means is, when you're crashing into dialysis, means this patient barely sees a doctor, never sees a doctor, starts feeling bad, shows up in the ER, and all of a sudden, when he's in the ER doctor comes up to him and goes, "Hey man, Your kidneys aren't working anymore, and you're going to be on dialysis for the rest of your life. So that's the experience of a lot of dialysis patients. I think hearing estimates that's 20 to 40% of all new starts on dialysis are people crashing into dialysis. The other drawback of this model is the underutilization of kidney transplants. So we have, tens of thousands of people in this country on waiting lists for transplants. I think maybe 100,000 people on the waiting list, and also you have people not being referred for kidney transplant as well too. So these are all the drawbacks of the current fee-for-service model. To challenge this, we had the executive order on kidney health come out. It was signed into law by President Trump in 2019. It is being carried forward by the Biden administration. It is brought to initially by Secretary of Health of Human Services Alex Azar, whose father had kidney disease. He actually had dad was on in-center hemodialysis, peritoneal dialysis, and got a kidney transplant. And so they came up with this, which was supposed to be a bold new system, a system that pays for kidney health rather than kidney sickness. How do you get there? And this is where I want you guys to, I'm giving you a more general overview of what this executive order has, but these are the 3 goals of the executive order. By 2025, 80% of new end-stage kidney disease patients, they want to start dialysis at home or get a preemptive transplant. Again, anyone newly diagnosed with end-stage kidney disease in 2025, they wanted them to do dialysis at home or get a transplant before they even need dialysis. Okay, so that's the goal. That's not the current people that are on dialysis. That's the new people that are going to start in 2025. By 2030, reduce the incidence of end-stage kidney disease by 25%. And by 2030, double the number of kidneys available for transplant. And these are high goal kind of things, I don't think they're attainable in many respects, but I think you have to set a high goals to get good results sometimes. But that's essentially the goals of the executive order. So what is value-based care? I'm not going to go into detail about value-based care, but what value-based care means is that you're not necessarily driven by more revenue, more vet visits, or more procedures. And instead of getting visits in a fee-for-service way as you do them, you get capitated payments, either monthly or quarterly for a practice. Okay, so that's what it means. A capitated payment means you get a payment every quarter or every month. And what happens is, so instead of seeing a patient every 3 months and billing, say $150, $200 to an insurance company for that visit, I myself may get $250 every quarter, and that's it. And how many times, if I see them every month or I have to see them once a year, that's how much I get paid. Do you see what I'm saying? So it's a capitated payment. What's good for our practice is this is a continuous revenue stream for a practice, right? The bad part is, how do you manage that patient to make sure you don't spend more on him than you're actually getting in his income? And in this scenario, you're not judged by more revenue, making more money. You're judged by saving costs, better mortality, and less hospitalizations. Now, value-based care isn't something new. It's kind of the buzzword now, but it has been around for quite some time. Medicare Advantage plans, if you guys know about those, Medicare Advantage plans are actually value-based care. They're typically run by a commercial carrier, but they're actually a Medicare product, right? So, but they are that. They have capitated payments and all that kind of structure. That's been around for a while. But CMS, Center for Medicare and Medicaid Services, came up with new kidney care models with this act. This executive order. There are 3 models: the ETC, KCF, and CKCC. You do not have to know about them in detail, but if you do, I'm not going to go over them in detail, but if you do, you can check out my website, Your Kidneys, Your Health, and I actually did a video on them, 20 minutes long, and you can actually see what the models are about and how the reimbursement system works for them. Okay. Now, how do you change to value-based? Guess what? Most practices can't do it. They don't have the logistical support. They don't have the analytics. They don't have the dietitians, the nurses, the staff to do it. So all these players came to the market. You may have heard of these guys: the Strives, Somatises, Cricket, Monograms, Evergreens, Panoramic. These are the new players on the market. They partner with practices to help them make more value-based. They partner with payers. So this is where the dynamic is now, whereas some of them are more practice-focused, meaning helping practices become more value-based, and others are more payer-focused, meaning they go directly to Medicare Advantage plans, they go directly to commercial carriers, and they say, hey, we'll help your CKD population or your dialysis population to manage them better for you. Also, the 2 big major players on the dialysis scene, DaVita and Fresenius, are creating their own value-based models as well too, and value-based divisions in their own startups as well. So they're getting into the game of managing patients well, because they see the tea leaves and they see where the market is going. Now, all that being said, with all that being said, the system right now is not totally value-based. It's mostly fee-for-service, right? So I'm going to go over what the fee-for-service model is and the incentive structures within that are, and then we can go from there. Now, just so you know, the stages of kidney disease are 1 through 5. 1 is where the 90%, stage 5 is less than 15%. You gradually go down, the disease progresses, and you eventually wind up on dialysis. You wind up on dialysis typically at stage 5 when your kidney function is at 15% or less. I'm not going to go into the management of kidney disease. I think the Alio patch could have application, especially late stage kidney disease, eventually, but you do need a fistula graft for it, right? So most patients at that age stage don't have it. So eventually you can get that, but we're just going to talk about dialysis patients particularly. Now let's talk about the patient experience, okay, on dialysis and what they go through. As far as the patient experience, on an in-center dialysis, again, they go to a center for dialysis. When they go to a center, they do hemodialysis. Hemo means blood, okay? So hemodialysis is blood dialysis. It occurs 3 times per week, Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, okay? Each session is typically 4 hours. What you do is you take the blood out of a person, put it in a machine, clean it for them through an artificial filter, and then return it back to them. Again, 3 times a week, 4 hours each session. Needles are placed in the arms in either a fistula or a graft or a catheter in the neck, right? They can do a catheter here or your fistula graft in the arm. And the fistula in the graft is where the actual patch goes, right? This is what an in-center dialysis looks like. Just so you know, this is that's a dialysis unit that sometimes they're freestanding like they are. Sometimes they're part of shopping centers, right? You can see them there. That's the inside of a dialysis unit. That's 5 chairs. These things get huge. You can see them with 30 chairs, 40 chairs, 50 chairs sometimes with multiple shifts a day. So that's how a dialysis unit runs. It almost becomes very factory-like, if you will, right? With repeating shifts and stuff. In-center dialysis, again, that's what the chair looks like. That's the fistula. Yeah.
Add, Qasim, that's probably the nicest dialysis center I've ever seen.
Oh, is that right? Yeah, the ones I just showed you right there. Yeah. There's some
most of the ones that I've seen are, make you really upset.
Yeah, they're not clean on the inside. They're not very. They're clean, but you know what I'm saying. They don't have the best atmosphere.
Yeah, they're dingy and all that.
Yeah. Anyway, so this is what the dialysis center, it looks like. That's the arm. That's where the fistula is. You see that arm there? That's what a fistula looks like. You put needles into the fistula. Let me go over what a dialysis access is too. So what a dialysis access is and what you guys understand it is. So see that guy's arm there with those lumps? That's a vein, right? That's actually a fistula. So a fistula is the actual vein of a person that's been connected to an artery. The artery pumps blood down your arm. So if you ever touch your pulse and you feel that thing, you feel that pulse down there, that's an artery. So you take an artery at the elbow joint and you connect it to a vein. Remember, your veins are like these small little blue things, right, on your arm. You connect that vein in your arm to the artery. All of a sudden, that artery is pumping blood directly into that vein, and that vein is getting bigger and bigger and bigger. That vein right there, that huge vein, is no different than that blue vein you're looking at your arm right at your elbow joint. It's no different. It's just been connected to an artery. A surgeon like Dr. Whitaker would create them, and that's how big it can get. But sometimes your veins aren't big enough, right? Sometimes your veins aren't big enough, or they're too brittle, or whatever. And if they're not, if you look at that drawing there, you can actually see that white tube. The white tube is actually a graft. So if the veins aren't big enough, you can actually use a graft to connect to the artery to actually have an area to stick. And that's how you stick. You stick 2 needles in these fistulas, guys. You stick one to take the blood out, the other one to put the blood back in after it gets cleaned. Okay, and the patch goes on in the middle usually of it, and we call it the dead zone, right in between the 2 needles. That area, that's ideally where we want to put it, right? Lastly, on the right there, you see that that's a catheter in the neck. That's what we want to avoid. And I'm hoping that the Alio patch can prove that we avoid extra catheters and things like that as well. But a catheter essentially is a tube that goes into your neck vein, down right into your heart. They have higher rates of infection. They have higher rates of complications and all that stuff. That's what they want to avoid. That's a part of the whole optimal starts thing that they want to do, optimally start a dialysis on a fistula, okay?
Qasim, why is it called the dead zone?
I don't know. I think we came up with that, right? The dead zone, like that's what we came up with. I didn't think that was a new thing.
Yeah,
So we. Huh?
Yes, sorry, Qasim. I agree. It's the first time I ever heard it was with Alio. So it's not.
And it's just in the, so typically you have 2 areas along the fistula that you actually stick needles into, right? And so that in between those 2 areas is where, I guess that's where we ideally want to place the patch. Some issues I have with that is sometimes the real estate you have to stick is not that big. So you want to make sure that patch doesn't take up too much real estate when it does it. But we came up with that term dead zone. But yeah, you want to that. We just arbitrarily said that. But there could be other places along the fistula. Like this one clearly has other places where we could put it, right? Like it's a longer fistula. We could put the patch in a different spot. I'm not sure strategically why we put it in the dead zone. If Dave, you want to comment to it? Yeah.
My understanding from what I've heard from David is that the patch has been optimized to a certain level of depth in terms of the blood vessel.
Yeah.
And but it can be so, and it cannot be. And the other consideration is the what would be the word? It's the art of motion, or it's the turbulence.
Turbulence, yeah.
Downstream.
Yeah.
That isn't a good indication of what's going underneath. So it can be either placed over the dead zone or proximal, which is above. And actually, in Saudi Arabia, we noticed that most people's cannulation sites were so close to each other that most of the patients had the patch placed proximally to the cannulation sites, which means above the cannulation sites.
Yeah, wow. So what's interesting is there's supposed to be like a few centimeters in between those needles that you don't want to have what they call recirculation, meaning where you're taking the blood out and putting the blood back in, it recirculates. But every country is different, every technique is different, everyone may have a different thing. So I'm just curious as to why, but I think you just want a nice straight segment of a fistula. That's where you ideally want to put the patch that's superficial, right? That's where ideally I would think you want to put it, right? All right, so let's just go over the patient experience. So we talked about the dialysis access there. And again, we're in center. This is what I'm going at right now. So the in-center experience, what the patient goes through, they have a dialysis tech there. The dialysis tech actually sticks the fistula, puts needles into the fistula. You have a nurse there that's in charge. She may actually stick the fistula. She may put you on the catheter and things like that as well. You have a social worker there as well that handles all insurance issues, transportation issues. So anything that you have problems with, they handle. And you have a dietitian. So the dietitian goes over the kidney-friendly diet, discusses things like low potassium diet. What's interesting, even in the fee-for-service model, the dialysis patient has a clinical care team. Most people don't have this, right? They don't have a clinical care team. So a dialysis patient is special in that regard, that they have all these ancillary service, even in the fee-for-service model. Doctor typically sees them 4 times a month. You bill differently, but you can see them 1 time, 2 times, 3 times, 4 times, and you can bill the most when you see them 4 times. And I'm going to go over that payment structure in a second. Labs typically discuss once a month, meaning you draw bloods once a month. If the potassium is normal, you leave it alone and you just check it the next month. If it's high, it's usually checked monthly, but if it's high, you check it weekly to see if it's coming down. Okay. Occasionally, we love
Qasim,
yeah.
Can I interrupt here real quick?
Go for it.
Can you talk about the importance of potassium, the biology of it, and what the?
I did a whole talk on that, dude. I can send you that too. So Jeff has
that. That's fine. Just you go ahead and send that to me.
Yeah. So we have a whole talk, a 20-minute talk that I did for Leo, and we could talk. You can watch that as well too.
I think I know enough to be dangerous and put my foot in my mouth. So
yeah, that's fine.
Okay,
but
cool.
Again, so potassium typically is monthly. If it's off, they check it weekly. Okay, just to make sure it's coming right.
Qasim, on the patients who have high potassium, can that be not focused but concentrated within a select number of patients, or could any patient have high potassium at any given point?
It's usually in certain patients, meaning so some of these patients, when they're on their dialysis, they have what they call residual kidney function, meaning sometimes their kidneys are still working to a bit, and so they can actually regulate that potassium and get that potassium off. The other component is how compliant they are with diet, right? So you have to be on a diet that's low in potassium, and if you're not adhering to that diet, it can stay up. So some people are have chronically high potassium. If you miss a session, again, you can get high potassium as well too. Over the weekend, when you have 2 days off dialysis, you can get a high potassium as well too. So
you can arguably categorize some patients as high risk and low risk as it relates to potassium.
I would say so. You can see people that are running on the high side, people that are non-compliant. You can non-compliant with dialysis or non-compliant with their diet. Yeah, there's like a select few people that are high that have a high potassium chronically. Yeah.
Well, the reason I asked is one of the questions we've received from an investor is whether or not exactly that, right? Whether customers or payers, providers, etc., can say, you know what, I don't want to pay X dollars per month for every single patient. I don't see the need for it. I would instead cherry pick my high risk customers, or my high risk patients rather, and put the patch on them. What do you think would be our counter to that?
Well, if we're just talking about potassium, like, I mean, I think that the patch does so much more, and it has utility outside of that.
Okay.
The counter to that would be,
Well, that's one of your counters, I think. Yeah.
yeah,
Okay.
yeah. Like, I mean, it does so much more, like we're talking about it actually detecting problems in the fistula, pulse
Got it.
off, all this other stuff. So you're saying it's not just a potassium monitor, it's far much more, right? Blood pressure monitor, everything else too. So it's doing a
Hey,
lot.
Qasim, since you paid for the extra time, can I throw in my own thoughts too?
Yeah, sure. Go ahead. It's $14.99.
You got it. Because this is a question that Scott Davies asked as well, and I think it's a good one. So I think from my perspective, from the investor response, you've got a couple different approaches. You can read your audience. So the one is to sit there and just to remind them that the idea here is to really improve the overall care of the patients. So our goal is to get to the point where all dialysis patients are wearing these all the time.
Yeah.
So that's the goal, right? However, you can also get to a sort of a de jure and a de facto, and a reality that is, I think, and I think Qasim would probably agree, that there are those patients that once they're going, like they go through these phases where they're good to go for months. And you know what? Everybody, including the patients, is going to probably be like, I don't need to do this anymore. And you know what? That's okay. But the reality is, and this is what I tell everybody, it's like Hotel California. You can check out, but you can never leave. Every single fistula graft will have a problem. It just will. So once they start, so I think what you could do is you could acknowledge their comment and say, we agree that there will be those patients that respond very well to dialysis and don't need it for intervals of time, but all patients will need it at times during their dialysis. That's part one. The second part I just want to bring on, Qasim, is the maturation phase, which I think is a huge one. So when we create a fistula up front, the fistula typically, if the nephrologists are good and they're spotting this and they send it for a fistula creation ahead of time, that's great. But it still takes about 6 weeks for these things to mature in general. And during that time, there's not an incentive for them to be seen. So it's not uncommon for these patients to have their fistula established and then show up either for dialysis 4 weeks later or 6 weeks later, or follow up for their follow-up appointment with me in a month and the fistula is just down or it's not maturing. So all patients, once the fistulas are applied, you could actually argue are excellent candidates for that period of time. So every patient's going to start with one, and I think every patient's going to eventually have one. There might be some intervals of time in between. So hopefully that gives you some talking points to use with the investors in that.
Or actually, the other thing I think you have to do,
just add to that.
Oh, sorry, go
I
ahead.
might just add to that.
Go for it.
Which is, if we think about us as an insurance product managing long tail risk, even in the healthy patient, the cost of a fistula failing in a healthy person is so great that it justifies even for the low risk patient to have the device. And Maddie is a wonderful story there, where she's been on dialysis for over 20 years, and I think her fistula was, the current one, I think, over 9 years old or something, and she doesn't. She would regularly not do blood work. She assured us that she was the patient who would never use our device, etc. And she went away for the weekend, felt a bit funny, didn't really have any indications that anything was off, and then started to feel funny, got tested, and I think her fistula was within hours of completely dying off, kind of thing. And when that happens, I mean, that's thousands of dollars
I agree. Like, so, and I think that's like the idea, like, where we're taking data points that are typically interval, meaning done weekly or monthly, and we're making them real time. And so it's like, you're going to have to change in behavior of how we deal with that. And like to Simon's point, I think dialysis access management is going to be crucial, and some of the costs can be dramatically improved even with the current way, not just when fistula stops working, but other issues, save money there too. But yeah, so let's see here. So just so you know, with the potassium, when they get a little report card at sample dialysis, so they get a report card, and they're typically given, when they get the report card, like little affirmations are given, stars, smiley faces and stuff like that on their report card to make sure they're doing okay. Then the home dialysis, so home hemodialysis. I'm not going to go into the other type of dialysis, which is peritoneal dialysis, which is the stomach dialysis. That does not involve blood, does not involve needles. So the patch currently, in its current form, it's not going to be useful on them at this point. But home hemodialysis, instead of being 3 times a week, it's actually 4 to 5 times a week. Each session could be 2.5 hours each session. Same thing, blood is run through an artificial filter, needles are placed in the arm in a fistula or graft. The thing about this type of dialysis, and this is the one that the executive order wants to go for, we want to do more home dialysis. It's more flexible, you have more autonomy. So you can go to work, you can schedule, I can decide that day I want to do dialysis at night, 2 hours of dialysis at night, as opposed to, at a set time in the morning. Oftentimes with the home hemo, you may need a caregiver at home though, someone to stay by to either help you set up the machine or help stick the fistula or just be around, right? You're having blood taken out of you. They may just want you around just to make sure you're doing okay. As far as the home hemodialysis market, you have this machine here on the side, like the next stage machine. That's the machine that's been around 10, 15 years. That now was acquired by Fresenius. The newer one on the market is an Outset Medical machine, which is the Tableau device. The Tableau device is really fascinating because it's a pretty cool advancement. It's essentially a lot nicer, more user-friendly, has this nice like iPad device in the front. As opposed to next stage takes 30 or 40 steps to set up every day, whereas the Outset Medical device takes about 10 to 15 steps. So usability and ease of use are really crucial for this company, and they've really innovative along the way. Hopefully one day we can actually make a partnership with them at some point. The patient experience for home hemodialysis, you have a patient or caregiver that sticks the fistula, so you have to be able to stick the fistula yourself, or have your wife, husband, whoever stick that fistula, and you do dialysis, and you do the dialysis yourself. So that involves things like dexterity, vision, competence, mental agility to actually do that. So that could be inhibiting home dialysis use sometimes. The nurse is not there, but she's on call 24/7. So you have a nurse there on call 24/7. Again, you have a social worker that handles all insurance issues and transportation issues. Dietitian discusses diet. In this scenario, though, the doctor only one visit a month. That's it. 1 visit a month. You don't have to do the 4 visits. You just have to see him once a month, and you just have to do a telehealth visit. Now you can do a telehealth visit too. Labs are discussed once a month. The thing at the home hemodialysis, oftentimes potassium is not as much of an issue. And the reason why is because of the more frequent dialysis. Remember, you're not doing it 3 times a week. You're doing it 4 to 5 times a week. You have less high risk of higher potassium. And oftentimes these patients don't have to have as restricted diet on potassium as well. As far as the market itself, the major players on the market, the U.S. market, are Fresenius and DaVita. They control about 80% of the U.S. market. As far as brick and mortar locations, DaVita has about 2,800 units and Fresenius has 2,500 units. So they're the 2 major players on the market. Reimbursement. So who gets paid, and how do they get paid? So I'm going to sound a little morbid, but once a patient hits dialysis, they become an annuity payment. Okay. And you can say it for the nephrology practice, you can say it for the dialysis provider as well too. Okay. Meaning you get a certain payment every month, and the average lifespan of these patients is about 5 years. So 5 years of an annuity payment. Okay. For dialysis providers, I'm going to go into these in detail. Dialysis providers get a bundled payment for dialysis services. Then there's some line item things that are considered outside the bundle that you can charge for too. Then you have this other thing, this is for innovative devices, the T-pennies, and I'll go over into that as well too. For nephrologists, how they get paid, they get a monthly capitated payment. Remember, we talked about capitation, but even outside of value-based care, nephrologists are getting a capitated payment for their patient care. They get hospital billing when they see them in the hospital. And then they also get other ways of billing, RPM and RTM. And I'm going to go over those as well. And I'm looking forward to Tom and Steve's insight into that as well. Then you have other players involved as well too, vascular surgeons, interventional nephrologists like myself. I bill fee for service for my procedures, whether the access is clotted or needs a stent or needs a balloon. I get paid fee for service when I do it. Hospitals and other doctor services, they get paid fee for service as well too. As far as the dialysis providers get a bundled payment. Okay, a bundled payment. So back in the day, everything was line item. You did something. You gave a certain medication, you did a certain procedure, you got paid separately. the CMS caught on to this because they were getting overbilled. They said, no. You're going to get a bundled payment, meaning all the costs of dialysis are included in this payment. That includes dialysis machine usage, filter and tubing, most medications, nursing and tech labor, and overhead. So this is what's included in the bundle payment that CMS gives every dialysis unit that they give them monthly, okay? And that monthly rate is based off the ESRD base rate. And that base rate, I think this is when I got this one for 2022, is $257.90 per dialysis session. So every time a patient does dialysis, a dialysis provider gets $257, okay? Now, if they have commercial insurance, and when I mean commercial insurance, I don't mean Medicare Advantage plans. Medicare Advantage is run by commercial carriers, but it's billed at CMS rates. If you get a commercial, like let's just say, God forbid, I go on dialysis and I have commercial insurance, Blue Cross Blue Shield. My Blue Cross Blue Shield is not paying $257 per dialysis session. They're probably paying 2 to 5 times that amount. So a commercial payer is considered a cash cow for a dialysis provider when they get that in there. Now, again, you have the base rate, the ESRD base rate, 257. Occasionally, you have line items, things, medications, and things like that. They're not included in the bundle. They're considered too expensive or too rare or whatever. And CMS says, okay, you can bill every time you give this medication. Examples of this is a medication called Epogen, which is a erythropoietin stimulating agent. What that means is that these patients have anemia. They need a hormone shot to balance that anemia. In the past, this was considered outside the bundle because it was so expensive, and you're like, CMS were like, we're reimbursed. Guess what? What happens is outside the bundle, and you get to bill for a line item, you get overutilization of it, right? So, someone's entering the room. Ava, okay. And in fact, DaVita got in trouble because of their Epogen usage in the past. When they put it in the line, when they put it into the bundle payment, and said no, Epogen is included in the bundle payment. All of a sudden, the utilization of that drug went down. And recently, that happened with a drug called Parsabiv. In 2021, they did the same thing, and the utilization of that drug went down as well too, because it was considered part of the bundle payment, not a line item thing. As far as dialysis providers, well, you have the T-pennies. T-pennies is the worst acronym ever, but okay. It's actually used for more innovative devices. And the acronym stands for Transitional Add-on Payment Adjustment for New and Innovative Equipment and Supplies. One of the more recent and public companies to get this is Outset Medical for their Tableau device, okay? And so this essentially gives the dialysis provider an additional payment to utilize this new innovative device, okay? And that typically is the add-on payment for equipment is typically the equipment has to be new, meaning within 3 years of FDA marketing authorization, have a HIPSIC, I guess it's HCPCS level 2 code application. You have to apply for it. Has to be innovative and not a capital related asset. Now, typically a dialysis machine is a capital related asset, but they made an exception for the Outset Medical device. And so they actually get dialysis providers actually get an additional payment stream for using the Outset Medical device. And it's typically for 2 calendar years starting in Jan 1 or whatever year you want to use it. So for the Outset Medical machine, I remember hearing it's an extra $200, $300 a month that a dialysis provider gets to utilize this machine. You see what I'm saying? So it makes the expense of using the machine less cheaper. Now, this is something maybe Ava, hi Ava, we could look into as well. I'm not sure if we do qualify for it, but it'd be really interesting if you've applied for this level 2 code application. And I actually found the application, and I found CMS's criteria. I can email it to you guys if you're interested in it as well too. So the T-pennies, that'd be interesting if we did qualify for that. As far as nephrologists and how they get paid, so for a dialysis patient, again, remember annuity payment, right? So a monthly capitated payment. So if I see a patient once on dialysis in a month, I get paid $183. If I decide to see him 2 times, I get $238 a month to see him. Now, if I see him 3 times, it's the same payment of $238. Now, if I see him 4 times, I get the full payment of $284. So at $284 is the payment I could get every month if I see that patient on dialysis 4 times a month, okay? And then you have hospital visits. So if that patient is hospitalized, I go to the hospital and I still bill fee for service on a daily basis when I see that patient there. So that's another revenue stream that a doctor could see. Now, what you have to understand about dialysis as a whole, quite honestly, the incentive structure in CMS has incentivized ESRD. I'm just saying it, but it's true. Because you have major revenue streams coming to nephrology practices from dialysis patients and dialysis units, okay? So you've, in a weird way, incentivized that. And let me tell you what I mean by that. First off, you have a revenue stream from patient billing for the visits. Like I said, that monthly capitated payment. So you're getting that payment. So that's, as I said, almost like an annuity payment, right? Then these units need medical directorships. So the medical directorship can pay $50,000 a year, $100,000 a year, whatever. And all you have to do is a 1-hour meeting once a month. That's it. And you get a medical directorship fee as well too. That go to the doctor, can go to the practice. Thirdly, you can be a joint venture. So Fresenius, DaVita, US Renal, Satellite Healthcare, they go up to nephrologists and say, hey man, look, we want to build this dialysis unit. You want to come in with us? And it could be a split of 60-40. It could be a split of 51-49, whatever it is. Typically the majority owner of it is the dialysis chain, but you go in as a part owner of the practice. So you get a part of the billing that dialysis providers get, right? Like the base rate, the dialysis base rate and all that other stuff, the profits they make on the dialysis unit, you can get as part of a joint venture owner. And then you can also get the ownership of the building. The dialysis unit, if you have a good relationship with them, they can actually say, hey man, you want to build a building for us and we'll rent it from you. And so they can actually get rent from that as well. And lastly, with the dialysis access, so the dialysis access itself, like for instance, my previous practice, we have a dialysis access center, ambulatory surgical center. We made money off of that. So every time the patient needed work on the dialysis access, whether putting it in or fixing it, ballooning it, stenting it, whatever, you make money off of that. So in many respects, the dialysis unit actually entails a lot of different revenue streams for our practice. Okay. Then this other thing, the other thing I would bring up, and this is where Steve and Dave and Tom, they can put their inputs in as well too. But remote patient monitoring, this is one aspect of the Alio patch that I think we could utilize or as an initial starting point. But remote patient monitoring is a code for CMS that you can actually bill for, and this includes 4 physiological readings of blood pressure, physiological readings of blood pressure, blood glucose, weight, or pulse ox. And I just happened to go on a website of a company that does RPM, and these are the codes that they actually came up with, these different codes. So initially you have a setup. So if we set up fee of a reimbursement of $20 per device. And then if you do it on a monthly basis, the daily device use, you can bill up to $56 a month. That's not, you don't have to get, it doesn't have to be used every day. It has to be, I think you have to get like 16 readings, and that counts as the daily device use. And then you can bill $56 a month. Again, this stream is going to the practice, right? This is where it's going. And then on top of that, you have another code, the 99457, which is billable time of 20 minutes. So if you take 20 minutes to read over all the blood pressure readings you got and say, make a decision about it or not make a decision about it, but you document 20 minutes of billable time, you can bill additional $52, okay, a month. Now, if you spend more than 20 minutes, you can get to 40 minutes, you can bill an additional $92. So on a monthly basis, it could be the daily device use of $56 and the 20 minutes of billable time of $52 as well too. Okay, so that's how you could bill a remote patient monitoring device to CMS currently. I found this from that same company, a hypothetical scenario for say you had 250 devices on 250 of your patients, conceivably could get $56 times 250, that's $14,000. $52 times 250 is $13,000. That's a total of $27,000 a month you could conceivably get off of a device, a remote patient monitor, if you got all those 16 readings. And interesting enough, I was reading you can actually combine other things. So if you get like 16 blood pressures and so you don't get 16 readings, say you get 10 blood pressures and 6 pulse oxes, I think you can combine those 2 readings to say 16. Do you see what I'm saying? And say that those are 16 readings. And again, our device is real time and gets all the data. But from an argument standpoint, if you're talking about this 250 patients, conceivably you can get an annual reimbursement of $324,000 for a practice, right? That's how you can conceivably get it. They threw in on this device, particularly, they said you can get someone, hire somebody to actually manage this for you for $40,000 a year, like a medical assistant or something. And the device cost, whatever it is, you can subtract that. But this is a possible model that you could go after if our device has a certain whatever whatever price point is. Now, the other code that came out is the remote therapeutic monitoring, the RTM codes. These are new for 2022. This is non-physiological data. This is not.
I'm sorry, Qasim.
Yeah.
Sorry, Qasim. Just going back to the prior slide, I just wanted to ask.
Yeah. This is mine, but yeah, I kind of jacked it from the website, but go for it. Yeah.
No, that's fine. I just wanted to ask Adarsh and Aya if they had any questions on this particular slide. Because this is exactly, I think, what we need to drive towards to answer, questions that we're getting from investors and also potential customers. Like they want to know what's the reimbursement pathway here for the providers who wouldn't otherwise, realize the huge value upside from prevented hospitalizations and all of that sort of stuff. They require the reimbursement, so we've got to educate them on how do you potentially pay for this in the current world.
Yeah, I think this is crucial. Like this could be our intro. Like this is how we get in, right? Like proving cost savings is really hard, and so if you have a reimbursement scheme, like this is actually a good way to get into. So, but yeah.
Yeah, Qasim, I'd like to have a more extended conversation with you on this.
Yeah, totally. And I would say Tom has some great insight into this stuff too. So how's about this? Let me go over the RTM thing too, and then we can go into discussion as well too. Is that cool? And then
yeah, of course. Yeah, it wouldn't be right now. Is what I meant.
Oh yeah, cool. Okay. As far as nephrologists too, you can get the RTM. So the RTM is new for 2022. This is non-physiological data. This is not the blood pressure, blood glucose, all this stuff. This has to do with things like therapy, like medication adherence and response to therapy. And then right now, currently, it's limited to musculoskeletal system status and respiratory system status. Okay, so our device has an accelerometer on it. You wonder where that fits in with this kind of thing. And again, this has 5 general CPT codes, very much mimicking the RPM codes as well too. And these are the codes for it currently. And again, same thing, a device setup fee. Again, the device setup fee is $20. So that's how much you would get for the device setup fee. Then you have the monthly rates of about $55 to actually monitor it. And then treatment decisions, $50. So if you realize it's about the same as like the RPM components. I talked to someone today who actually is doing RPM. You can combine RPM and RTM at the same time. You can combine them together. Now the interpretation side of it, the extra $50 or whatever, I think maybe kind of fuzzy. He said that's kind of almost like a bundled payment where you can't bill that twice, but you could bill the component of the non-physiological data, the accelerometer stuff, that you can bill that. So I would wonder if you can bill both. The only thing is, Dave, we talked about this, but when I was reading about it, this is supposed to be for a therapy and to get to an endpoint, meaning someone's post-operative, like they just went for a knee surgery. We're wanting to get them up and moving and see what their mobility is like. Once they're back to normal, you stop paying for it. Do you see what I'm saying? So I think there's an endpoint to it. I don't think the RTM is in perpetuity like the RPM. You see what I'm saying? And maybe I need to be corrected on that. But I think this is to get you to the endpoint. Even the spirometry, if you had like a COPD exacerbation, you were short of breath when you went to the hospital, but over time you got better and you're back to your baseline, maybe you can't bill for it. But again, I need to do more research on it and get correct on it and see. But that's the RTM payment right there. And this is my thing. I think I said Tom and Steve, like, and I sent this to Ava like months ago, but I sent an email, and if you want to see it, about where I think the Alio patch has a value capture, where we can capture things. So from the dialysis provider side, if we get our electrolyte game up completely and we can actually have hard numbers and say we deliver hard numbers, we can save money for the dialysis providers on sending out serum labs. Right? They don't build getting serum labs is included in the bundle payment. So if you can save them on that. Also, with all the metrics we do, we can help them with CMS metrics. Every month in a dialysis unit, we have a quality meeting to go over all the metrics in our hospital, in our unit. And if we're doing really bad on them, the next year, our payments can go up or down. Do you see what I'm saying? So those quality metrics, we can improve those quality metrics, which affects eventual adjustments to payments by Medicare for the following year. Anemia management can be a big deal. Again, anemia is with the blood, where I talked about that drug Epogen. the Epogen and what do they call it, erythropoietin stimulating agents are extremely expensive, and they're included in the bundle payment. So CMS the dialysis unit can't bill extra for them. So they have a vested interest in utilizing that drug as efficiently as possible, right? So anemia management, especially with the ESA spending, the erythropoietin stimulating agents, that's a big deal. Anything that prevents a hospitalization is a big deal for a dialysis provider as well, too, because every time they miss a dialysis session in their dialysis unit, they miss out on the bundle payment of $250, right? They miss out on it. So if a patient's in the hospital for a week, they miss 3 sessions, they're out $750 for that hospitalization. You see what I'm saying? So that's another way. If the device can prevent hospitalizations, we can prevent that loss of revenue. For insurance and payers, you can save money on the hospitalizations. Again, the people that pay for the hospitalizations are the insurance, right? So save money on hospitalizations. Also, you can save money on preserving dialysis access. And me and Whitaker could probably shoot the shit on this forever, but what I was going to say, but it can lead to better management, getting an access healthier, quicker, maintaining that access, and to less expensive procedures. And I've gone into detail with AVO like this, but let's just say an access has a narrowing in it, and I go in there, balloon it open. That's about $2,400 billed to Medicare. If that narrowing goes to 100% and it stops working and it's clotted off, when I go into there to do a declot, get all the clot out and everything, I'm billing Medicare $6,000 or $5,000 or something like that. So that's a huge cost savings if we can prevent a clotting event. You see what I'm saying? Not just a narrowing event where I just balloon it, but a clotting event. So that's a big deal. And the people who pay that are the insurance payers as well too. And by the way, when we talk about value-based care, and if you're trying to incorporate value-based care, you have to think it from the cost of the insurance and the payers. And so, and of course, the last one I would talk about is physician and the possible revenue stream of RPM and RTM as well too. So, but yeah.
Hey, Qasim, real quick, do you know the percentage of patients when they experience a clotting event end up in the hospital because of that? And I mean,
I can't comment to that. I was looking up data. I was trying to look up data on that. And I have to go into detail about that. But like, if you're in a rural facility, if you're 2-3 hours away in rural Idaho or wherever, you're probably going to go to a hospital, right? So the whole point here, and me and Ava's talked about this numerous times, is to detect problems early and avoid a hospitalization, meaning get it done in an outpatient setting in an ambulatory surgical center or an office-based lab where a nephrologist runs it or a vascular surgeon runs it and can do it as an outpatient, because outpatient billing is substantially cheaper than inpatient billing, right? Or getting them hospitalized. So I can't comment to the extent of how much it is, but a lot of America is rural America, right? Or a lot of people don't have access to these things. So they wind up, if their access is clotted, they wind up going to the ER. So that's
Qasim, is there an economic incentive though for the vascular surgeon to get people in the door? Honestly, like, I mean, unfortunately, right? Is there a perverse economic incentive for there to be more procedures?
Yeah, and I guess
go ahead.
Well, I'll jump. First comment is in terms of timing, like how many of them end up in a hospital. I think another key part is just it really depends on when it happens. It's part of one of the concepts behind version 0.5 is if it thromboses on a Thursday at 6 p.m. And the person's potassium is high, they're going to get admitted because they need to have a temporary catheter placed, and then they're going to have the declot done, and no one's going to do it until the next day or the day after. So as opposed to if they show up at Monday at 8 a.m. and then the whole system's flowing and can accommodate them. So I think that's one point. And the second thing is there's I shouldn't say for everybody, but in general, there's so much business to go around in terms of the interventional aspects of this and I'm very cynical when it comes to vascular surgeons and the likes of that and perverse desires. But there's really not when it comes to the dialysis access. Like I really don't see people saying, I'll just let it go for a little bit and it'll thrombose. It's a real pain in the neck.
Yeah, I got asked that question too. I think it was maybe Ava, but yeah, like would I prefer a declot, right? And and pay bill $6,000? No, I wouldn't, because it's a pain in the ass. And so it's like, and on top of that, you don't want it, you want to prevent it, but it's not like, it's not the same. You see what I'm saying? And you can say that.
Yeah.
And there are perverse models. Like I did mention a lot of perverse models here, right? Or like incentives,
Yeah.
right? So I don't think that's one, but go ahead.
No, I was just going to say, I wouldn't want like anybody to make the analogy that we're going to the broader marketplace of plumbers and the tool that we're using will, diminish your need, so to speak.
Right.
Yeah.
Right. But what you're suggesting and saying makes sense. Okay.
Yeah.
And I think investor response to that would be it improves the quality of life for the patients, but also for all the providers and healthcare system taking care of
All the providers up and down. Okay, got it.
Yeah.
So we can continue to rely on even physicians to be advocates for the product in a big way.
Right.
Oh yeah, I definitely think so. Like even like you gotta remember, like me and Dave like work on access, but most nephrologists don't work on dialysis access, have no understanding of it. So it's not like it's like everyone in nephrology is going to be like, we need to increase these procedures. You see what I'm saying? They're not going to be like, oh, we need more thrombectomies. So it's like it's not like that. Like but there is a kind of a weird perversion in nephrology in the sense that you want more dialysis patients because that's a huge revenue stream. You see what I'm saying? So but yeah.
Actually, Qasim, and another good anecdotal story for you, just from investor perspectives. I would say over the last 2 weeks, any vascular surgeon that I see, who I know well enough to ask this question pretty bluntly, I say, what frustrates you the most when it comes to dialysis access patients? And everyone, I mean, I'm not even exaggerating. Everyone's response is getting a 6 o'clock at night phone call that their dialysis graft is a thrombosed.
Oh, absolutely, absolutely, man. I think like it's a pain. It's a pain. It's not something we look forward to, if you could imagine. You see what I'm saying? So it's like
so much easier if you get the call at 8 o'clock in the morning, or you can deal with it during the daylight rather than after hours. And
I think it's one of those situations, Dash, where you actually value time more than money. You see what I'm saying? Like in those kind of procedures,
Sure.
It's like such a pain in the ass. It's like, God, I know
Like
I make more.
cost.
Yeah, there's an opportunity cost. Like I'm missing out on other procedures, other things to do and stuff. And even though you make more, like you can, the Dave talks about peripheral leg work, where a lot of people are doing runoffs in legs, stenting legs, where they're making a lot of money. There's a lot of perversion there, but yeah, I don't think in dialysis access that's there. I would actually love to hear if Tom and Steve, whoever, like about the RPM and RTM revenue streams that are possible and what they think about it. I'm just curious. Are they there? Did they leave?
I'm muted.
Oh, okay.
Yeah, certainly. I mean, the CMS requires, obviously you have to fall under specific diagnostic categories. So you have to be diabetic, hypertensive, whatever. So most of that's covered. In reality, the revenue stream created by that simplistic model doesn't really occur in real life. There has been a struggle in almost all RPM programs to get the required numbers of readings on a consistent basis, and to some extent the 20-minute interaction with the data or the patient. So it is a process and a workflow that has to be built in. The good news is when we get our biometrics up, the 16 readings for our patients are automatic, and that's a huge plus. Because that is a lot of times a major deterrent to getting the monthly reimbursement. The RTM I'm not as familiar with, to be honest with you. I think you're correct that it is episodic, meaning there's if you have a physical therapy, 3 months of physical therapy or occupational therapy or whatever qualifies. I know it's not ongoing like RPM if you have a chronic condition. I don't. Does anyone have any questions specifically other than that? And
you can combine them too, right? The RTM and RPM.
Yes,
is that right?
Absolutely. And there's a number of other codes as well that are affiliated with this as patients are released from the hospital. There's some doctor visit codes that you can incorporate in these programs that really enhances the reimbursement on a monthly basis. So. The RTM, I haven't really done any programs with that because it's brand new and I don't really focus on that, but I know it can be done in conjunction with. Okay. Steve, have you done an RTM?
Well, I just don't want to throw cold water. I do every day to keep in mind that the average cost of a system, is $25, $30 a month for the technology portion that's billed to the doctor. And then there's labor involved to get the 20 minutes. So you can't come out with 100. I tell other people that come out with products to say, we want to charge $100, $200 a month for our product. Well, I don't know that it's going to work because other products only charge $20, $30 a month for the whole platform. So no, we've got a unique niche. And I've told David, I believe that we should partner with specific people that want to do it, that can bill it and share with us a higher percentage of the revenue than what a primary care doctor or a cardiologist. The biggest market is hypertension. There's monitoring blood pressure, and you give them a cellular blood pressure cuff. They use it every day, and data comes up. It costs them $20 a month for the technology and software and everything else, and they can bill for the 150.
Well, I would say one thing our device has over the other devices is the other devices actually need patient input or patient behavior, right? They got to take their blood pressure.
Correct.
They got to check their blood sugar. They got to take
does
their
the
pulse ox.
RTMs. That's the
Yeah.
problem. The RTMs.
Yeah, but our
really
device does
don't.
it on its own. If it's on the fistula, it's doing it, and we're getting data, extracting data. So that patient behavior component's not there, or patient participation is not there, right? So need for it at least, right? So I think that's an advantage we may have in that kind of market, right? Is to
Well,
say,
big
hey,
advantage, no question.
big
As
advantage.
Tom said, compliance is an issue. I just
Like-
wanted to make everybody aware that these reimbursement codes are very competitive. There's a lot of players in the market trying to get those codes. And so, like I say, I deal with it every day. It does require a specific piece of software that we'd have to build in. That's what the money is. The $20 a month is for the software more than the device. You can buy a cellular blood pressure.
I thought the
cuff.
$20 reimbursement was a one-time initiation setup. No,
Well, no. I'm talking about as a vendor. So I'm speaking at you as if Alio is a vendor wanting to charge for our technology.
got it.
When you compare it to a vendor that has a software with a wireless device, which is what it requires, there are people offering that for $20 a month as a vendor.
Oh,
I don't want you to get excited that you can get 150 or 200 or 300 for the technology. Some people might pay that, especially with these high-risk patients that are, certainly on dialysis, and I believe we should try it. But I just wanted you to be clear that to get for a nephrologist to get paid, all he's got to do is ask them to take their blood pressure every other day with a blood pressure cuff and have it come up to the software. The softwares have to, and the reason they get the $20 or whatever, they have to track and report those time-stamped readings. And when you put 20 minutes of time in, they're like a lawyer or an accountant. They track the time by who did the work. And so that's why electronic medical record systems aren't doing this. It requires a specific software as a service to manage the data and report on it to get reimbursed.
cool.
Yeah, the bottom line, Qasim, is that the device has to be within the parameters of the reimbursement
Mhm.
as a general rule. And I'll make another point too. Those numbers in that example are just for a specific state. It does vary state to state.
Yeah, it varies. Yeah,
Yeah.
absolutely. It varies per state. Yeah, it varies per region. I think they were just giving a general example of what
Yeah,
you can
yeah,
build.
and they just probably picked the state they were based in or whatever.
Yeah.
But in any event, if you're within the parameters of the technology reimbursement, which is generally mid 50s to low 60s, and then the first 20 minutes of review, which is another 40 something to 50 something. If you stay within that parameter for your device, particularly if you have value add over and beyond just a traditional blood pressure or whatever, your product is marketable. But it obviously, if you exceed it, it's going to be a tough challenge. Then you're into, this is how you manage your value-based or your caps or capitated payments or whatever, on top of the reimbursement. So just food for thought for those who are in the pricing business.
Cool. All right. Any other questions, guys? Or hope it was helpful to you guys. So.
No, very.
Qasim, this was great. And again, and I think we all know you well enough now that we can just reach out as these questions keep popping up.
Yeah,
So
yeah.
thanks
So
again
I'm
for
always
listening.
open, guys. Like you can get me on Slack. You can just text me if there's any questions you have about nephrology or just like the experience or whatever it is. Please feel free to reach out to me and let me know. So